My name is Muhsin. I'm a psychiatrist at the Department of Psychological Medicine. Welcome to today's CME. So today we are talking a little bit specific field in the field of epilepsy and mental health. So we always talking about epilepsy in terms of diagnosis and so on. But today we are more inclined to a discussion on the beyond that is on the mental health. So we'll be talking about beyond the diagnosis, mindfulness living with the epilepsy. So to lead today's discussion, we are delighted to introduce Dr. Lai Siew Tim. Dr. Tim is a registered clinical psychologist and senior lecturer in the Department of Psychological Medicine. She earned PhD from University of Malaya and also holding master's degree in both clinical psychology and health psychology. Beyond the university role, Dr. Tim also is appointed a council member for International League Against Epilepsy, Psychoeducation Task Force. She is also a life member of Malaysian Society of Epilepsy and affiliated to the Malaysian Society of Neurosciences. So I think she's in the very right position to talk on this topic. So I pass the floor to Dr. Lai Siew Tim.
All right, very good morning. So I'm Dr. Lai. I am a senior lecturer in the clin psych based in Department of Psych Meds. So the topic for today is beyond the diagnosis, mindful living with epilepsy. Now, this topic will be mostly based on the project that I'm working on and also the work that I am collaborating. So first and foremost, let's talk about epilepsy. Epilepsy is a chronic neurological condition that affects 50 million people worldwide. This makes it one of the most common neurological conditions. Nearly 80% of people with epilepsy live in low and middle income countries. However, it's estimated that 75% of them are not receiving proper treatment due to poor access to care facilities or poverty. So this makes them at a higher risk for premature death and also suicide. Among all these risks, there are actually greater risks in terms of developing psychiatric comorbidities. In fact, it was often highlighted in forums and in the ILAE board that psychiatric comorbidities are very common for people who are diagnosed with epilepsy. So with that being said, this approach in terms of looking into the relationship between epilepsy and psychiatric disorder. In the past 10 years, research has shown that actually there is a bidirectional relationship between epilepsy and psychiatric disorder. It's not only unidirectional. So in psychological ILAE Psych Task Force, the statement released in 2018 urged that psychological interventions like what they recommended was cognitive behavioral therapy, mindfulness-based therapy are very effective in terms of promoting seizure control and well-being. In fact, recent systematic review for neurological disorder, we found that it was one of the most commonly used therapies, mindfulness-based approaches. So a little bit background about what is mindfulness about. It has been existing in the psych stream for as long as 1970s. Mindfulness is not like some kind of Buddhist chanting where you sit down and just be very passive. In fact, it actually requires a person to pay attention. It's not just paying attention just like that, but paying attention with intention. So that's why it's very on purpose. And in the present moment, which is the now, and the non-judgmental attitude. For this, actually requires a person to cultivate this attentional control. This benefit of mindfulness has already been documented in terms of different population from non-clinical sample to clinical sample. So mindfulness, when you talk about the benefits in neurological condition, it also has been established in conditions such as Parkinson's diseases, multiple sclerosis, stroke, and so on. And also for epilepsy patients. However, in this synthesized study, right, there is no profiling in terms of epilepsy types and no assessment. So that puts into the report back to the ILAE stating that when we develop psychological interventions for epilepsy, we must consider the GRADE GRADE recommendation, which looks at the clinical meaningful effects, looking at specifically the symptoms of the disorder being treated or the functional outcome. So back then, what we talk about functional outcome is actually looking at the reliable of change. This reliable of change index uses a specific calculation to evaluate the scores between pre and post test. So the index actually determine how a person change across time, right? With that, when I conducted the study for mindfulness for epilepsy, I'm focusing on the following outcomes like depression and anxiety, quality of life satisfaction, and mindfulness. I want to see how effective it is from pre to post as well as the follow up. Okay, so I won't walk through the methodology because this one can actually look into the paper that's already published, but mostly it's conducted in UMMC as a very small trial with the following inclusion and exclusion criteria, randomizing 28 samples into the intervention and the waitlist control. So it's a 6 weeks program which taps into the following outcomes that participants require to complete, right, measures. So the intervention is carried out 2.5 hours on a weekly session, right, in a group less than 15 people. The combination of a brief lecture, which often focuses on what is seizure management, medication adherence. Each session will have different brief introduction, small mini lecture series, face to face. Whereby they are conducting, whereby they are engaged in group activities, and then are able to discuss what went well or what are the hindrances that they face when they are doing the practice in a supportive environment. So in the session, we have meditation practices where teaches the patients to be aware of the breath, the bodily sensation, and the thoughts and emotion. Whenever the mind has wandered, orient them back to the breathing. So this is actually not a seizure control technique. It's actually teaching the respondent to be more skillfully knowing how to respond to stress, uncertainty, and difficult internal experiences, in which they are also asked to do a daily home practice. So the format is 6 weeks. This was a protocol that we have developed and managed to publish. So walking through the findings, it's very small sample but feasible enough. Of the 28 participants, most of them are female, single, attain tertiary education and above. So mostly we had a profile of drug-resistant focal epilepsy and monotherapy. The primary outcome, we can see that as a group, right, after 6 weeks of mindfulness implementation, you can see there's an increase in mindfulness immediately after the intervention, and an increase in quality of life and a reduction in depressive symptoms. All right. There's also significant differences in terms of level of mindfulness and quality of life follow up. Right. Same also for depression, levels of depression. But there is no significant findings for anxiety and life satisfaction scores. Right. It's the same also for the follow-up. But when we look at individual changes, so just now what we see is a group effect. This one actually track point by point for individual changes. You can see that that the score is also similar to what we find in the group setting. And you want to see here is that reliable of improvement. This one actually show the proportion of how many don't respond to treatment, how many is the same, and how many actually improve. So there's a significant finding for depression, quality of life, and levels of mindfulness. So as a whole, we can say that from group and individual findings, reliable of change index, mindfulness implementation, just a brief 6-week program, right? Able to have reliable improvement about 36 to 46% of proportion in terms of anxiety and depressive symptoms, and so on for quality of life and life satisfaction. So it's not really such a bad thing. As a group, of course, these are the notable changes because the study is rather small and it's very hard to actually get patients to commit as epilepsy patients couldn't drive and mostly rely on their caregivers and so on. Also, the cohort here is not those who frequently experience seizure, right? There's also only limited to those who speak English. So those with learning disability, suicidal ideation, other comorbidities were actually excluded. So you won't know if it actually works for who have other symptoms or health conditions. Nevertheless, from this reliable of change index is something that we look at percentage of improvement, and it's very important when it comes to research-based study. Because this one would allow us to dictate like, how many patients actually respond to treatment, and we can look at whether we want to target the improvement or what makes them not change. So it's important in terms of clinical practice to identify the so-called dosage, right? So in terms of future direction, of course, larger sample trials with symptomatic changes and effective measures to look at the clinical utility of mindfulness. In terms of the mechanisms, then qualitative study is important to look at what changed and what doesn't when they talk about from their experiences. In terms of policy, it has always been the ILAE goal uh, to say that hopefully epilepsy treatment uh, is mainly is aiming for seizure freedom. Any type of seizure freedom also requires medication. Not saying that implementing mindfulness means you do not take the med. Rather, it's something that we can incorporate in our treatment plan of epilepsy. So this is also stated by the task force saying that it's important to refer patients for psychotherapy. However, I just want to bring light into Malaysian context when we talk about uh, the broader scope. Of course, this is the policy. This is what the task force is interested about. In the Malaysian context, um, when you talk about integrating care services, this is a recent paper that our group have published in 2025. There is a stigma in terms of referring patients to at site treatment. Sometimes we ask about who is the one that is responsible. So if you say like the top tier epilepsy care center, we would hope to have such services. Of course, uh, there is barriers towards the waiting list and so on. So that being said, the ongoing psychoeducation and advocacy is needed. Hopefully by I'm part of the ILAE task force member under the psychoeducation. When we talk about integrating site care services, there are many factors to consider, especially when we trying to implement in our country as well. So hopefully by collaborating with different networks and also with different uni, we are able to integrate psychoeducation into and psychological interventions in terms of outlining the epilepsy management. So this is concluding the end. We have an oncoming congress, and this is where we take the stigma and advocate for change. So that's
Thank you, Dr. Lai, for giving us insight on the neurology, which is epilepsy, and psychiatry, which is mindfulness. So I would like to open any question from the floor, from the audience. So while waiting for questions, if any, so I would like to ask one question here. In the routine outpatient clinic, which epilepsy patient perhaps more benefit to receive this mindfulness intervention, in your opinion?
you mean which cohort is it? Which
Yeah.
profile?
Yeah. What type of
Uh,
patient, what features in terms of patient could be from epilepsy profile or mental health profile that patient which is suitable for mindfulness intervention?
if you're talking about mainly just improvement in psychological health, right? Knowing that it's okay that they have a seizure, then I think actually not I think it's based on my group what I observe whether it's focal generalized epilepsy, they also benefit from it, or some do not. But I find that those who have focal epilepsy, they have aura. So when they are practicing mindfulness, it's not that the mindfulness stop the seizure, rather they are able to know that okay, I am going to have a fit soon because aura is part of seizure, and they are able to actually find a place and calm down or breathe through it, and then the attack happens. So in that sense, I did a focus group. Uh, I find that those who have focal seizures actually uh, are able to use mindfulness to calm their breathing to get the when is it gonna happen, and then calm themselves down and sat at one corner. Mm.
Because in my opinion, it could be two outcome, a very important outcome. The mental health outcome and the control of the seizure is another good
Mm-mm.
outcome. Reducing reliance on the treatment, medication. So, as I'm a psychiatrist, I know that reducing stress could reduce the occurrence of the seizure itself. So, mindfulness might be contributing in that way as well. So that is like double impact, not only reducing mental health, but reducing the occurrence of the seizure itself. Okay. Any other question from the floor? If none, I would like to wrap up this session. I would like to thank to Dr. Lai for sharing your research finding on the mindfulness role in the epilepsy. I wish your conference also runs successfully end of the year. Okay. So thank you everyone for being here this morning. Thank you. Have a good day. Thank you very much. Bye.